Welcome, everyone. We're thrilled to see you all here. My name is Doug Owens. I'm the chair of the Department of Health Policy in the School of Medicine and the director of the Center for Health Policy in the Freeman Spogli Institute for International Studies. We are thrilled to have you. We are very much looking forward to a very informative event today. At Stanford Health Policy, our mission is to advance policy solutions to improve health. Crucial to that mission is addressing health equity and health disparities. It's core and central to everything we do, and so we are really delighted to have this group of outstanding experts together, and we can learn from you all, and are very much looking forward to that. As you well know, the events of the last 3 years have shined a light on health disparities, things that we've known about for many years, but the COVID pandemic made it stark. So we're going to have experts in law, economics, epidemiology, population health. We hope that you'll participate and ask questions. We're going to have a keynote that I'll introduce our speaker in just a moment. And we're going to have 3 panels. They're going to look at health equity and disparities from 3 different lenses. One's the social determinants of health, one's technology and innovation, and then finally, access and affordability. So policy work is incredibly important because you can affect millions of people with good policy or, of course, with bad policy. So we feel that there is an important lever here, and we want to use that lever to do the most that we can to address health equity and health disparities. So now it is my privilege and honor to introduce Dr. Kirsten Bibbins-Domingo, who really probably doesn't need any introduction, but Kirsten and I met many years ago when we were on the U.S. Preventive Service Task Force together. The task force develops national guidelines for prevention, takes on many challenging topics. And there I saw Kirsten first as a scientist, an extraordinary scientist, an advocate for policy, evidence-based health policy. Saw her as a compassionate and caring physician. She always brought the perspective and voices of her patients to our discussion. She was a national leader for many years in health equity and disparities and helped the task force tackle those. And she was an extraordinary leader. She chaired the task force, and it was a master class in leadership. And she's had many other leadership roles. She was chair of Epi and Biostats at UCSF, where she's still a professor. And as you probably know, she's now the editor-in-chief of JAMA. For those of you who aren't in medicine, JAMA is by far, in a way, one of the most important journals in the world in medicine, and they are incredibly lucky to get her, and we're very excited to see what she's going to do there. So, she's a national leader. I can't believe that you were able to do this. We are thrilled, Kirsten, that you could come here. I know you must be unbelievably busy. So please join me in giving a very warm welcome to Kirsten Bibbins-Domingo.
Thank you very much. So whenever Doug invites me, I try to say yes, especially when he invites me over and over again. But it was a real honor to get an invitation and realize that this is your inaugural symposium of this type for this Department of Health Policy, which is really quite special. I have a lot of friends and colleagues who are here, and it's really a pleasure. I love that you have chosen this topic for your symposium today, and really pleased to give this keynote. So this is an area, the area of equity is one that has been important to me, but as important has been how do we think about building out a research infrastructure, a scientific infrastructure that actually helps to enhance and promote and advance health equity. And that's what I'm going to talk with you about today. I'm going to talk with you about the very specific area that I have worked on most recently. So this is a committee that I ended up chairing for the National Academies of Medicine, Science, Engineering, and Medicine on improving representation in clinical research. I have to say they invited me to chair this committee during the pandemic when I was busy doing a lot of hands-on things in the pandemic, as many of you I'm sure were as well. And I almost didn't chair this committee because I said, I don't want to do another committee that says, oh, representation in clinical research is really important, and so therefore we should do it. When we've been saying it my impression at the time was we had been saying it for many years and had not made as much progress as we would like. I received reassurance from the committee chair that they were very interested in policy recommendations that really could advance this area. And you all will be the judge of whether we have produced that type of report. What I can say is that we had really an extraordinary group of people who come from research and health equity research specifically, people who are from health policy, people who are patient advocates, people who are economists. And I have to say, an Academies Committee meeting remotely on a topic like this really has to have the energy of the people who are coming in the room to say, we actually have to do something more. And this committee certainly brought that. The report is actually co-authored by myself and Dr. Alex Hellman from the National Academies of Science, Engineering, and Medicine, and I have the link to the report at the very end of the presentation. So, why should this matter? The issues related to health equity are far bigger than our research landscape, but why does the way we generate knowledge and knowledge that it informs our ability to deliver care to patients, to design policies, to deliver public health interventions, why does it matter that we have representation in the types of research that we do to generate the knowledge base on which we make design evidence-based practice? So I want to convince you that there are seven reasons, at least these are the reasons that the committee came up with. The first is that it starts with the science, that this is really important for good science. If we don't have a knowledge base from which we are generating evidence, and we intend to apply the results of this knowledge to the populations in the US, and this is an increasingly diverse population in the US, then when we fail to develop an evidence base from representative samples, we are compromising generalizability to the clinical research findings. And so it limits the generalizability of our findings, and I think it limits their applicability. The second is that it may actually hinder innovation. So I come from a basic science tradition, and in the basic sciences, the broad range of variability in response is actually the way one can uncover new innovations that can generate new hypotheses, make new discoveries. That's in the basic science frame. The same would be true in the behavioral sciences. And when we, sometimes in an attempt to create more homogeneity to see an effect in a large clinical study, we miss the opportunity to see those things that are about variation in that overall effect. My favorite example here comes from the PCSK9 inhibitors, which for those of you who might be clinicians, you'll know these as our superstatin drugs. And the PCSK9 inhibitors are drugs that were discovered, they're really a miracle of basic biology informing targets that would design new therapeutics. But there's a great epi-story within it, too, of understanding in mostly black, in a large cohort of black patients, a few who had very low LDL levels because of modifications in this pathway that ultimately informed how we think about this pathway that PCSK9 inhibitors are designed to exploit. It turns out those drugs then are not uniquely used in that particular patient population. These are innovations that benefit larger groups of patients, but the ability to understand variation in biology, variation in behaviors is one of those things that oftentimes can trigger generation of new hypotheses and lead to new discoveries. And then the third is that lack of representation may compound low accrual. So about half of clinical trials in the US fail because they don't accrue enough patients. The NIH knows that this is a problem, and that if we have designed an infrastructure that works for some patients and not for other patients, we're probably not helping this particular aspect of low accrual that does cause trials to fail. So, the second category of types of reasons that representation might matter relate to clinical care and then the application then of our findings. So lack of representation may lead to lack of access to effective medical interventions. We oftentimes approve medical interventions because based strictly speaking on the patients in whom they were studied. So some have very narrow tailoring of indications. That will apply to things where we limit to age categories because those were the age categories that are studied, and it's only later that we expand to other age categories. You might think about this during the pandemic, while it takes work to design clinical trials that work for pregnant people, the lack of information about vaccine effectiveness in pregnant people very much hindered our ability to effectively roll out vaccines to that particular population and that were really important for public health and public policy during the pandemic. Lack of access may also limit ability to get care for the state-of-the-art care for particular types of interventions. So for cancer treatments, for example, clinical trials are actually where the most cutting-edge treatment is actually available. It's in the context of clinical trials. And when you don't have an infrastructure that actually is able to recruit patients from diverse backgrounds, you might actually really, in a very literal way, limit access to the most important therapies at a particular time. And then lack of representation may actually undermine trust in our treatments. So we oftentimes think of communities that don't participate in high numbers in clinical studies as the problem is they don't trust science, they don't trust medicine, there's historic mistrust, and I'll get to this in a little bit. But it is also the case that when we then roll out interventions and people don't see that their community is represented in the groups from whom the evidence is derived, also can undermine trust. And we saw that same thing happen with the vaccines during the pandemic as well. The last category relate very specifically to health equity. So it is, of course, the case that those populations that are underrepresented in our clinical studies, in our research studies, in our database studies, are actually those who are more likely to experience gaps in health and adverse gaps in health and health disparities. And so if we are not studying in high enough number, that could in fact compound the very health disparities that we at least seek to address if we're trying to address the health of all of our populations in the US. And what I hope to convince you of, and what is part of the work that we commissioned for this report, is that these health disparities actually cost a lot of money. So it's always a little bit dangerous to talk about economic modeling to like a health policy crowd, but this is not mine, but it is a study that we commissioned and was done by a group at USC and Dana Goldman's group. So Dana used, and their group used the Future Elderly Model and the Health Retirement Survey to look at the cost of disparities across 3 common conditions in the United States. He was interested in the outcomes of life expectancy, disability-free life expectancy, and work years gained. Basically, if the disparities, if the outcomes were the same for these conditions, diabetes, heart disease, and hypertension, as white men, that's the comparison group in this particular study. So he's modeled here for 30 years, and we're only looking at these 3 conditions, and that diabetes, the disparity cost, if we could eliminate that disparity, would result in an increase in life expectancy of nearly a year, an increase in disability-free life expectancy of more than a year, and an increase of years in the workforce of about half a year. We have similar results here from this modeling exercise for heart disease. Again, more than a year in life expectancy, a year and a half in disability-free life years, and about a third of the year increase in the workforce. And then with hypertension, again, very similar, nearly 1 year, a year and a half for disability-free years, and about a third of the year's increase in the workforce. So in this model that is included in our report, basically, if these life expectancies were eliminated, just for the 3 conditions that were examined here, the value here is roughly 20 trillion over a 10-year period. And so the value then for even modest reductions in these disparities due to better representation could be on the order of billions. Now, of course, you're going to come back and say, well, yeah, putting more people in clinical trials is not necessarily going to impact all of those things that contribute to disparities. But the point here is that the number here is quite large in terms of the cost of these differential outcomes across only these 3 common conditions. And that certainly some of the ways in which we invest in our clinical research enterprise is to improve population health and is to improve the health of all of our communities in the US. And so the value to actually studying with the goals of improving health, even if it were to only contribute to this overall reduction in these disparate outcomes to a small extent, would have a very large value in terms of dollars. So the example here is that if 1% of health disparities were alleviated by better representation, it could result in more than 40 billion in gains for diabetes and 60 billion for heart disease alone. So these are the 7 reasons the committee laid out at the very outset. They relate to the good science that we'd like to achieve in the US. They relate to the clinical care that we'd like to be able to provide to all of our patients. And they relate very specifically to health equity, to the communities, the populations in the US that are disproportionately burdened by many of our most common disease states, and addressing those, at least through research to some extent, would have a very important impact, both in terms of life and in terms of dollars. So, if it's important, how are we doing? So here, I think the most striking thing for me was to really go back and look at 3 decades of very clear statements from federal agencies. Statements saying, this is important. Researchers have to tell us how they're doing. We prioritize this as an agency. You see this across the funders, across regulators, across those like the FDA, who are sort of gatekeepers to getting new discoveries out into new interventions that can reach the population. What is striking is both how long we have made these commitments, how very little data there is to tell us how well we're doing, and when you put together the data that does exist, how little progress we've made. The good news is that we have made some progress in improving representation of women. They represent over 50% of clinical trial participants in the US, and this is data now from the NIH. They do a look at theirs. They've done reports over a report that they've completed 3 times over the last decade, which is where most of this data is derived. I will say another take-home here was that the clinicaltrials.gov data was very, very challenging to look and to gain any sort of useful insights from. So the good news is that women are represented over 50% in our participants, but there's a lot of heterogeneity, and that pregnant and lactating people, sexual and gender minority populations, and certainly racial and ethnic subgroups of women remain underrepresented. And then if you look at the overall representation by racial and ethnic diversity in clinical trials, this has been largely unchanged over 3 decades, and there's a wide variation across the NIH in terms of institutes, where some, like allergy and infectious diseases, have about 25% participants from racial and ethnic diverse backgrounds, whereas the National Cancer Institutes is only 10% in any given year when we look at the representation. And so really striking both the variation and the lack of progress. So what are the barriers that are commonly cited, and what did the committee find in terms of how important these barriers are? So probably most often cited is that there are just some people who don't want to participate in our studies, and there might be reasons of historic mistrust and distrust that lead people to say they're not going to participate in our studies. And while this is frequently cited as a problem, the people who do study this say it does exist, but it is certainly not a factor that cannot be overcome. And in fact, there is no more evidence that people from Asian, African American, Latino, American Indian backgrounds that when they are asked, they participate in the same rate or higher rates. And so oftentimes the barrier is that they are not asked and that there is no infrastructure to actually to do the hard work to actually reach the populations that we are talking about here. So mistrust and distrust matter, they exist and shouldn't be ignored, but these are not insurmountable barriers to participation. And in fact, there are other barriers that are important that the committee identified, and we did this by talking to a number of groups who actually do this type of work. These are barriers in individual studies, and it require really an examination of the research processes that make it compatible with participation from people from different backgrounds. There are institutional structures that pose barriers. They may not oftentimes be aligned with academic incentives or the timelines for promotion if people are doing work that really requires sometimes more time and effort in order to engage with the particular communities that we want to participate in our studies. We know that certain sites that we might be more able to recruit different populations, like community sites, might face additional challenges to recruitment. We know that there are policies in the IRBs designed ostensibly to protect participants from participating in studies, oftentimes put up barriers that make it insurmountable or make it harder to engage different communities in participation. We know that this is going to cost money and that this is not oftentimes built into the way research is funded, and this can pose a barrier. And then this is now of increasing importance to me, but that medical journals, by deciding what they publish and what's not acceptable to publish, create environments where they are either encouraging the continued publication of studies that don't have diverse representation or not. And we see this in like clinical trial registration, that once we move to requiring trial registration and journals saying, well, we're not going to really publish anything unless it's been registered, unless we can see the pre-specified outcomes, created shifts in how things are practiced. Okay. There are also some facilitators to inclusive studies, and there's a very rich section in this report where we talked with a number of groups that have done the hard work in doing this, and so I only have the main ones here, but that doesn't do justice to all of the things that people told us about what works. Starting with attention and agency, saying that this is an explicit goal from the outset. Establishing a foundation of trust with the communities and participants at large. Actively anticipating and removing the barriers to study participation. Adopting a flexible approach to data collection and recruitment. Having a robust network. There's a lot about investing in infrastructure over time that brings on all of the stakeholders who might be important to doing this work. Navigating scientific, professional, peer, and societal expectations. There's a lot about the norms in academic institutions that don't necessarily favor this. Optimizing the study team to ensure alignment with research goals, and attaining resources to support and achieve representativeness. And I'm going to give you just here 3 quotes from the groups that we've interviewed. I think the goal to get to full equity with community partners, writing grants, getting the money, sharing everything from the ground up to the study. I think we're still unequal with academic partners. So doing the grant writing, getting the funding, working with community partners, giving them funding from the grant, unfortunately, there's still a hierarchy. We have to break down that hierarchy. We have to get to parity as much as possible, and that's going to take time, and it's going to take investment. This is from another group. We had to be very flexible in how we collect the data. We ultimately end up giving people multiple data collection options. We've tried to enroll everyone, do baseline survey collection in person for folks for literacy reasons, to understand comprehension and for trust building. After that, they can meet us in person or in clinic. They can meet us in person or in our research offices. They can do it online or via REDCap. They can do it via phone or with a research assistant. They could have mailed paper surveys. And similarly, they can go in for a test in clinic, or they can just have it mailed. So reinforcing the idea of meeting people where they are and the flexibility. And then I think it would be good for efforts to recruit and retain these folks to have the potential additional budgeting. So it's like there's a $500,000 grant, but you're going to recruit over 40% of folks from low socioeconomic status, and there's an extra $50,000 a year for direct costs to support these efforts. If we're going to do this, we have to put our money where our mouth is, and I don't see that this is happening. So, what must be done? So here the committee was faced with 30 years, not a lot of progress, no inherent barriers in the particular communities that are not well represented in our clinical research studies, and the urgent need to do something now and to do something that would scale. And so our recommendations are really policy recommendations. They aren't at the level of, oh, you should do your enrollment forms these ways. There are a lot of tactical things that the groups do and are important and are in our studies. But our recommendations really focused on what could we do now that addresses the need to really have a more diverse, representative people participating in our research studies in the US. So these are the principles that underlie our recommendations. The first is that this issue is urgent. We have made very little progress. We have an increasingly diverse US population. And without more deliberate action that is coordinated across the many entities that play an important role in the complex clinical research ecosystem, we won't make progress. Improving representation is going to require an investment. That means an investment of money. It means an investment of time. It means an investment in coordinating with stakeholders either at the very local level or stakeholders at the federal level in order to actually achieve this goal. One of the things that I would say here is that it was very clear to us that everyone says the right things when it comes to this, but very few people think that they have a responsibility. And the clinical research ecosystem is complex, and this requires everyone in this ecosystem to act with a little more investment in their part in this. This requires transparency and accountability. There's a lot of emphasis here on data collection and on actually, though, having mechanisms, both carrots and sticks, to hold people accountable and to realize that we're moving towards more equity in our research representation. As I said before, this is the responsibility of everyone involved, and I say this as a clinical researcher, now as a journal editor, but from our very individual perspectives, but also from the different agencies that are involved. Obviously, the federal government plays a particularly important role here. The federal government is a funder of research. It is a regulator of research. It is the gatekeeper to monetizing the results of research discoveries through the FDA, and it's also the purchaser of those new drugs and devices. And so the federal government, working in a coordinated way, could actually create the environment, but everyone has to see their particular role in doing this as an important one. And finally, we have I'm going to give you a flavor of our research recommendations. We think they're important. But this conclusion from our committee was also important, and that is that to create a truly more equitable future entails a paradigm shift. So the recommendations we have here are the first step, but really achieving research equity means required shifting the balance of power from institutions and putting at the center priorities and interests and voices of the community. And that is a much more far-reaching goal than is embodied in the specific recommendations, but we believe the specific recommendations are the first step. So, I'm not going to tell you all of them. We had 17 recommendations, but I'm going to bucket them for you so you can see how the committee thought about this. And then I'm really looking forward to a discussion on whether you're convinced by these recommendations, whether they might make a change. So the first set of recommendations really have to do with reporting. And again, the committee was quite dismayed that we have very little information in this area. This is a recommendation first to the Department of Health and Human Services to actually create an interdepartmental task force that could work across the many agencies that I suggested really have a role to play in creating an environment that enables and encourages improved representation in our clinical research enterprise. The NIH should standardize data collection, particularly since we have a mechanism through clinicaltrials.gov, and goes beyond existing guidelines. And we have several data elements that we've included in here that should be standardized and included, and that this data should actually be easily disaggregated, exported, and analyzed by the public, which was actually the intent in clinicaltrials.gov, but hasn't quite been achieved. And that journal editors and publishers should actually require information on representativeness of studies for submission to their journals. And you'll see New England Journal of Medicine took a stand on this, so they don't, they consider representativeness, as we all do, when we're deciding whether we should accept a study, but they also, with the study, publish the demographics of the condition that the trial is designed to address, so that you can judge that if a study on cardiomyopathy that affects mostly younger Black individuals and studies done not in that population could they reasonably generalize to this population? And I think it at least provides more useful information to give the reader the ability to judge the context of particular new study findings. The next is accountability. Again, one of the things that the committee felt was that there are mechanisms already in place to actually achieve some of these goals, but they're not enforced to the level that they should be. So the Food and Drug Administration should require study sponsors to commit detailed recruitment plans no later than at the time of new drug basically new drug applications to ensure that this population appropriately reflects the demographics of the disease or conditions understudied, and that CMS should amend its guidance for coverage with evidence development that requires study protocols, again, include information about the demographics of the populations being studied. The third set related to incentives, and this is arguably the one that I think caused the committee a lot of pause and a lot of discussion, and I would be interested in hearing your thoughts as well. And this was to say that the Congress should direct the FDA to enforce existing accountability measures, but then also to establish a task force to study new incentives for drugs and devices, for trials, that achieve representative enrollment. That Medicare and Medicaid services should expedite coverage decisions for drugs and devices that have been approved on the basis of clinical development programs that are representative of populations most affected by the treatable conditions, and that CMS should incentivize community providers to enroll and retain participants in clinical trials by reimbursing for the time and infrastructure that is actually required. The fourth category of recommendations relate to remuneration, recognizing that it actually costs to participate in studies. And that federal agencies, including the Office of Human Subjects Research Protection, NIH, and FDA, should develop explicit guidance for local IRBs on equitable compensation for research participants and their caregivers, and that all sponsors, federal, private, or industry, should ensure that trials have adequate compensation in their budget for research participation. And finally, we have a set of recommendations that recognize the need for a diverse workforce and for partnerships to achieve these goals. It was very important to the committee that it was clear that the responsibility for representation in clinical studies is not the responsibility of those in the workforce who might represent those particular groups that are currently underrepresented, but it is the responsibility of everyone because of the reasons we said at the outset. But that diverse and inclusive workforce and environments do create enabling environments to allow for this to happen as well. And that finally, that Health and Human Services should invest in community research infrastructure that it would improve representation in clinical trials and clinical research. So that is the end of my presentation. This is the link to the report. I'd urge you to go to this report. There's a nice executive summary, and then there's a lot of detail, including a number of commissioned papers that are included as the appendices to this report. I've given this talk to the NIH several times. I've given this talk to Congress. There have been several congressional actions related to the FDA and to the NIH on this topic. I've only now started giving this talk to an academic audience, so I would really value the input on what you think of our report, whether you buy our arguments, and what you think of our recommendations. So thank you very much.
Thank you for an amazing talk. Maybe let's start, since you're now the editor-in-chief of JAMA, an incredibly influential publication. What are your thoughts on how much leverage the journals have? And you mentioned this in your talk, that a group of journal editors got together and said, we will not publish your trials if they're not registered in clinicaltrials.gov. Do you think there are options for that kind of action, and do you think it would help?
Right. So I would say journals are talking about this a lot. They're talking about how we take steps from our role within a complex research ecosystem to encourage this in the way that you've talked about. We've also done a lot of soul searching on the composition of who makes decisions on editorial meetings and manuscript meetings, who was on the editorial boards. And so we are thinking about this a lot. I would say one of the things that make it not a quick and easy fix is that the big journals have an international audience, and the issues of very specific ways of thinking about representation don't necessarily are more complicated when you're thinking about an international audience. But in that way, and this is my own view on this, is that more information helps the reader to decide. And I think you will continue to. I think it's harder for journals to operationalize. We will never accept a paper like this. I think it does absolutely should be part of the review criteria for a paper, just like it is for a grant, the generalizability of a study to the population you intend it to generalize to. But I do think giving readers more information about the condition helps the reader to understand what that means. And I think it does put more emphasis then on the author groups to provide that information.
Great. Well, relevant to the answer you just gave about the international audience, one of the questions from the audience is, how should we think about the reference population for purposes of assessing representatives? Is it the population as a whole? Is it underserved population? Is it specific to the condition you're studying?
Yeah, I think it's a really good question. And I would say, so the committee was really looking at making recommendations for the overall, for essentially we're speaking mostly to the U.S. federal policymakers. And there, I think the NIH, I think large funders have the obligation to look at the distribution across their portfolio. What does it mean for an individual investigator who's doing a study of 26 people on a behavioral intervention? Like, what does representativeness matter there? I think it's hard to say that we meet numerical numbers for trying to achieve that there. I do think, like any good clinical researcher, this variable is no different than any other variable. Like, you should be clear on why you're asking this question, what type of results you expect to see, to whom those results should generalize, and what gap you're filling by choosing to ask this question this way. And then that should inform the population that you decide to enroll. And that might be that you decide, the gap we are filling here in improving diabetes care really should require that we focus mostly on low-income populations or on this particular group. So I don't think from an individual investigator we're expecting, that everything should be representative. I think that across the big funding portfolios, they really should be.
Yeah, great. Another question from the audience is that medical journals often want papers with data that's very current, but it may take longer to accrue if you're trying to reach hard to get groups. And are you all thinking about that? And how would you consider that as you're reviewing?
Yeah, I think it's a really good point. I think so. Our policy at JAMA is certainly we'd like to see papers within the last 5 years, and if you're collecting data that is outside of that, there really has got to be a really compelling reason why that is, why we're considering that paper that it has data that's a little bit dated. I will say there is appreciation, and I've only been on this job for a few months, but there is an appreciation of how hard it is to actually operationalize particular study designs, especially for populations, for conditions, for interventions that are understudied. And I can think of a number of occasions where we have considered whether the age of the data whether our strict rule on the age of the data was going to prevent something that was really compelling or timeless or important because it filled a gap. And I do think we think about that. But we do want it to be recent, right? Because, that helps us now.
Great. So one of your recommendations spoke to this, but one question is study participation requires time and adds costs. Isn't that a socioeconomic barrier? And it sounds like you considered that and suggested that needs to be addressed in some way.
Yeah, in fact, the committee, again, this probably will be viewed by some as controversial, but the committee actually came down on the point of allowing IRBs to consider differential compensation. So if the barrier to participation it's a responsibility of a study group to address the barrier to participation. And if that barrier to participation is greater, in fact, because somebody comes from a low socioeconomic background, then differential study participation should be allowed. It's one of those examples where the IRBs have a lot of rules in place that are ostensibly designed to protect study participants, but actually many times create higher barriers to participation. And one of the things that I learned in the process of this is that IRBs are very local, and that there's a lot of room to create more statements that could allow for local IRBs to act in a way that would really, I think, enhance the ability for investigators and participants.
Great. So one other question, we're going to getting close to the end, but how do you see people with disabilities being better represented? They might have the severest symptoms, yet face some of the most significant barriers to participation.
Yeah, thank you so much. I should have said at the outset, so that we were charged by the NIH to look at women and underrepresented minority populations by race and ethnicity. The committee felt very strongly that that was too limiting, that there are many groups that are really critically important that are historically excluded in our clinical research enterprise. People with disabilities would certainly be amongst them. We do have language in there. What I would say is, while I think that many of the calls that we have in the policy recommendations absolutely apply to other groups, and then there are specific issues related to specific groups. And so we've had a lot of good dialogue with people who've taken our recommendations and are using it to think about how they can expand it out into other groups that are currently also not well represented.
Great. I think we're going to do one more question, and this is one that you and I have both worked on, and that, on the U.S. Preventive Services Task Force. We know that many groups are disproportionately affected by lung cancer, colon cancer, breast cancer, et cetera. And when we try to make recommendations, that evidence is not there, and that's what all your talk and the report address. What are your thoughts about what we should do in the meantime? We don't have it, and you know, it may take years to get this, even if all these recommendations are enthusiastically received. What do we do in the meantime?
Is the right answer modeling?
It was kind of a setup. Modeling is the right answer to every question. But I'll let you elaborate.
I just wanted to make sure.
That is the right answer.
No, I mean, I think that you're right. These issues are urgent. It doesn't, I think one of the things that probably was most concerning to me on the task force when I joined the leadership group in the task force was going to stakeholders and to hear groups. We talked with a group who was representing American Indian advocacy group who said, well, we don't follow the recommendation because you don't use studies that we're not included in any of the studies. And so you quickly see how the implications of not being clear on who our study findings of, not being clear that even if we don't have diverse populations right now, that we do have an urgency in many of these issues to make sure that people realize that even with limited data, that the findings are applicable. And so some is a communications issue of, and I think the task force has done a really nice job not only to communicate in a way to address sort of the range, both address the issues of disparities, address the issues of representativeness, but also to think analytically about, well, how can we use other observational data, other data about the epidemiology, modeling studies, other things to help us to say, we have a core finding that this particular preventive service works. We know that the epidemiology tells us that other groups might have this condition earlier or later, things like that, and that it might be reasonable in the context of other smaller studies to think about how else to operationalize the recommendation. So I think that's all important.
Great, great. Well, we're going to have to wrap it up. To summarize her last answer, she said modeling is the answer. Kirsten, we want to thank you for your leadership, for a career of such amazing distinction, for coming down here at a time when you're just, getting going at JAMA. We are so, so appreciative. Thank you so much.